You know, the OPD Scan III has really just been an incredible benefit for both our patients and our staff. The staff finds the technology incredibly user-friendly, easy. It's easy to position the patients, and we can get great data very quickly. Not only just the topography, but really accurate and spot-on refractions. Patients can instantly sort of sense the incredible amount of information that you get and the technology that you get, so that not only does it really allow you to deliver better care to patients, but in a sense it provides a constant ongoing internal marketing of your practice, because the patients realize how much technology you have when you're helping to provide care for them. So we find the OPD3 really a critical component of our patient assessment for advanced technology IOLs. And in our practice, any patient who's even remotely considering cataract surgery, one of the first pieces of data we want to have access to is their OPD scan. If they're a candidate and we're considering using a toric implant for the patient, it's beneficial for numerous reasons. First off, just being able to show the patient their own topography and showing them their astigmatism is incredibly powerful and really helps lead the patient to understand why a toric lens is in their best interest and helps them in making that decision. Medically, being able to look at the astigmatism and assessing its degree of symmetry and its effect on the vision, which you get exquisite data on the OPD3 scan, is very helpful in knowing that a toric implant is the right decision for the patient. The same type of information is true for the OPD scan in multifocal patients. There's no other technology that I'm aware of that really allows you to so quickly assess higher order aberrations, angle kappa, and pupil size all in one quick, easy diagnostic test. So if I have a patient who I'm considering a multifocal lens with, I can look at their OPD scan and very quickly know the size of their pupil in light, the size of their pupil in dark, how many higher order aberrations they have, and what their angle kappa is like. So if I'm going to make a recommendation, I can make a recommendation for a multifocal lens with extreme confidence based on the OPD technology. Almost all cataract surgeons talk about an upcoming tsunami of patients coming in for cataract surgery who've had prior refractive surgery. And being able to calculate the appropriate strength implant for these people is really critical, because any patient who is willing to undergo refractive surgery to achieve emmetropia certainly wants to have emmetropia following cataract surgery. And the better information you can have to do your calculations, the better job you can do for your patients. We found the OPD3 scan really indispensable in managing these patients for two reasons. One is the data that it gives you, called the APP, or average pupillary power, allows you to plug in the average strength of the cornea into the Ascaris online IOL calculator, and we've had just exquisite results for our patients with all prior forms of refractive surgery, including radial keratotomy, hyperopic laser vision correction, and myopic laser vision correction. But the other reason why I like to have the OPD scan in addition to just the average pupillary power, or APP, is I think it's really important to look at the corneal topography in these patients. I'm always impressed at the number of people who've had prior laser vision correction that do have a permanent corneal cylinder etched into their cornea, presumably to treat a compensatory lenticular astigmatism. And when you take their cataract out, that corneal astigmatism will then become manifest. So many of these patients actually do become good candidates for a toric implant at the time of their cataract surgery. And again, without the data that you get from the OPD scan, being able to manage these patients would really be very, very challenging, and instead it's made it almost a routine event in our office. Often at courses, physicians will always ask, how do you determine if your toric implant is in the right position following cataract surgery, if it's shifted? To some degree, pragmatically, if the patient is seeing well and doing well, it may not be academic, but I'm less concerned about the position of the toric implant. But there will from time to time be patients either in your own practice or that you see in consultation where their expected outcome with the toric implant isn't as spot on as you want. One of the beautiful things about the OPD3 scan is it allows you to take a retroillumination image that lets you see the toric marks and place on the eye a reticule so you can see the exact axis the toric lens is sitting at. That, along with a number of the diagnostic calculators that let you assess how to manage the patient, is really critical in solving these occasional toric missteps that you may see in getting the best clinical result for your patient. In our practice, we have a referral practice for patients who've undergone cataract surgery and are now not happy with the quality of their vision. This comes up most frequently in patients who've had multifocal IOLs. And we found using the NIDAC OPD scan to analyze these patients is unbelievably beneficial. The ability to access data of their higher order aberrations and the internal aberrations of the eye can be essential and critical for analyzing what's going on. Many of these patients will have good Snellen and acuity when you have them read an eye chart or have them read a near card, but when you look at what the quality of their vision is like, and there's a number of displays on the Marco NIDAC OPD scan which will allow you to determine numerically their overall level of aberrations, it justifies and in a way objectifies the patient's visual symptoms, and it allows you to make much better clinical decisions as to how to manage them. So when we purchased the OPD3 scan, we really were interested in the technology to get access to higher order aberrations. But as we've used it more and more, we've been incredibly impressed with the different data sets that you get from the technology. And one of the nicest surprises has been a really objective and quantified measurement of pupil size in light and dark. And this is really critical in assessing patients for multifocal IOLs. If a patient has an extremely large pupil size and a resting pupil, then you may not want to go ahead with a multifocal lens in those patients. And I always had a concern when our technicians measured the patients prior to me seeing them if I was really getting a true, accurate reading of their pupil size. I like to see the patients dilated if I can, so that I can fully assess their eye. But once the patient's been dilated, you really don't have any idea of what their actual true physiologic pupil size is. The beauty of the OPD scan is the machine will assess all that data for me, store it, and I can go in and look at that data on the screen in our electronic health records, yet the patient can be dilated. So it actually allows the office flow to move much faster and much more quickly as I'm seeing patients, but it doesn't sacrifice any clinical data that I need to make the best decision for a patient. The OPD scan can be very helpful when trying to make a decision as to what form of advanced technology lens is best for patients. Some surgeons are comfortable using multifocal lenses in patients with high levels of astigmatism, whereas others want to use toric lenses. And in many patients, they could potentially be a candidate for both. The OPD scan is especially helpful in a patient who's considering a multifocal lens, but then you look, and they have astigmatism, but then you look and see that they have a fairly high level of higher order aberrations. So that's a patient where I'm very comfortable saying, well, I know you're interested in multifocal technology, but we're probably much better off going ahead with a toric lens. And it allows you to make that recommendation very comfortably for the patient. So the OPD scan has really become a critical part of our preoperative evaluation of patients. It allows you to acquire a tremendous amount of clinical data very quickly, so it makes the initial diagnostic workup of the patient very efficient. It then allows us to make a strong recommendation to patients about what technology options they have. Ultimately, the wow factor that patients achieve following surgery is based on a lot of different factors, most importantly their overall clinical result and how happy they are, but a lot of that does still go back to what their overall experience was in the office. Between the OPD scan giving us an efficient way to acquire tremendous data to make good clinical recommendations, and then allowing us to deliver on those recommendations, it's really a key component of delivering a wow experience for our patients. So we've had electronic health records on the next-gen platform for about 2.5 years in our office and have been 100% electronic health records. When we acquire any new diagnostic technology, one of our concerns is always how that technology will interface with our practice. We've been very pleased that the OPD scan has integrated quite well in terms of the data acquisition, so the technicians can do the testing in one section of our office, and that data is instantly incorporated into our electronic health records. When I see the patients in a different part of our office, I can bring up that data right away. When I go to the surgery center, I can also pull up the OPD scan if I want to double check on axis or corneal topography or anything else. So being able to integrate the technology fully into your electronic health records is just one other thing that makes for both better practice efficiency and better patient care. You know, before we had the OPD scan, we had optical biometry and we had manual keratometry, and we really got pretty good results with that. But to a large degree, there are many patients who would be candidates for advanced technology lenses that we weren't comfortable making that type of recommendation to them because we just didn't have enough data, we just didn't have enough information. Or unfortunately, in any practice, you do have an occasional patient where you do use advanced technology lenses and you just don't get as good clinical results as you desire. Since we've had the OPD scan in our practice, it gives so much more information, and the information is assessed so quickly that it allows us to make much better recommendations for our patients as to what type of lens technology would give them the best results clinically, and it really allows us to deliver on that promise. So I think it's been a real positive thing, both in terms of practice efficiency, but also more importantly in terms of better patient outcomes. Well, the OPD scan has really benefited all our patients because it allows us to make a best technology recommendation for them. When patients do well, they tend not to stick out in your mind. And so in a sense, there's a good thing that there's not a tremendous number of patients that I can think of where there have been issues with the OPD scan. It's only been a positive asset for our practice. But the one patient that does stick out in my mind with the OPD scan was actually a patient who was really a diagnostic dilemma. She had had prior LASIK surgery, she had some corneal scarring, and she was having progressive decline in her visual function. She was very frustrated. She's seen a number of different really high-quality ophthalmologists, and no one was in agreement as to what was causing her reduction in vision. When I saw her, she had subtle lenticular changes, and I actually felt that her cataract was likely the cause of her reduced vision, but none of the other consultants she had seen felt that she had a clinically significant cataract. With the NIDEC OPD scan and the ability to assess the internal higher order aberrations, we could see that almost all her aberrated vision was coming internally from her lens. Not only did that really allow us to clinch the diagnosis for her, but again, being able to show that objectively and graphically to a patient, it really helped her understand what was going on in terms of her vision and what her problems were, and as a result made the management of her reduced vision much simpler as well.